Hello, and welcome to the Evidence-Based Exercise Rehabilitation and Sport Performance channel. This channel is for the healthcare movement professional looking to incorporate applied research concepts into their current practice setting. Today, we'll be providing you with a lecture and lab on clinically assessing how to connect potential ACL injuries to the Lumbo-Pelvic-Hip-Complex.
So this is Dr. Andrew Doyle that is going to be taking us through this today. He also did this at GLADA as well too, and it was very well received. We had a room full of a whole bunch of people. It was a really cool lecture and lab. And do you do much of this in any of the classes that you teach?
Well, right now I'm currently teaching more undergraduate exercise science. So a lot of this stuff, unfortunately, is beyond what they need. So no, I guess I don't teach a lot of this here where I'm currently at.
Okay. And he's at Indiana University. He's at South Bend campus here. So I will, if you could give us just kind of a little bit more regarding your professional background and just kind of go from there whenever you're ready. We are good. We're up and recording. So have at it. It's all yours.
All right. Here, bear with me here as I navigate kind of my shared screen. I want to make sure you guys can see what you need to see here. And
you want them to
can you see my screen okay here, that demystifying title slide there?
Yep, looks good. Do you want them to hold questions until the end, or
no, I mean, go ahead and ask questions. I as Darren said and Dr. Smith said, this was developed in 2019, this presentation. So bear with that in mind, that some of the evidence that I'll provide to you today might be a little bit dated, but we're only talking about a couple of years. So maybe two, 3 years. So not too dated. So what I want to go through here is I have a couple of things here. I'd like to discuss a little bit about recognizing the prevalence of ACL injury among athletes. So I know Dr. Smith said, hey, we're going to talk about Mulligan, and we'll get to that point. But I also want to put a backdrop for you of understanding why this is important. And I'm sure you guys have come across ACL injuries, patients with ACL injuries. It's very relatable, and I think there's a strong connection with ACL and hip alignment. So I think after you watch and listen and learn through this discussion, I think you'll come away with an understanding that maybe we need to pay attention preventatively to the hip lumbo-pelvic alignment, because that could be leading to a lot of our issues, or epidemic, if you will, with ACL injuries in athletics. So we will be discussing some information regarding ACL. It may be a lot of stuff you've already kind of learned in some of your other classes. I get that. So we'll kind of go through that briefly. I want to make sure we have enough time then to go through some of the observations that I can help you with, and then also go through some of the maneuvers and coach you through some of that stuff. But you'll see a little bit of the language regarding ACL, and you'll be like, we already know a little bit about this. Yes, but hopefully you kind of get some numbers and perspective of why we're looking at the hip lumbo-pelvic region in regards to the ACL. So with that being said, recognize the economic burden of ACL injury is also one of our outcomes. We want to identify the relationship. That's the biggest thing between the hip flexion and anterior tilt on the glute muscle, angle pull on the femur, and how that could be predisposing some of our athletes to ACL injury, and how we could potentially correct that with some hip pelvic alignment strategies. So that anterior tilt could be causing some problems with our patients who have ACL injuries. Also looking at the hip lumbo-pelvic asymmetries, the lower extremity injury, and how they relate to one another. We also want to briefly talk about regional interdependence. You probably have already discussed this a little bit in some of your coursework. We want to also recognize the difference between mobilizations with movement or Mulligan and different strategies like muscle energy techniques to correct hip lumbo-pelvic asymmetries. Some of this stuff here, as we get through some of these outcomes near the end, is a lot of things that you've already used in your clinical practice as in getting up to speed in the world of athletic training, but also what you probably had in your coursework with identifying bony landmarks. You probably have a good grasp on that. I'm going to offer a little bit of refresher just to kind of make sure that we're all on the same page as we observe the hip lumbo-pelvic complex, because we need to have good palpation skills in order to identify any asymmetries that are observable. Now, I say observable, clinically observable, because we're not x-ray machines. We're not going to know for sure. We can only go by what's exhibiting clinically. Okay. And then apply manual corrections based on some common observed hip lumbo-pelvic asymmetries. This is our course flow. I want to give you kind of a brief backdrop, like I said earlier, about why this is important in regards to the ACL and how hip lumbo-pelvic alignment could be possibly influencing ACL injuries among specifically females. And some of the data show, and probably from your clinical experience, you're seeing that females tend to suffer from this injury a little bit at a more robust pace than their male counterparts. So we'll talk about the anatomy, the surface anatomy, specifically the bony prominences that we need to observe for an understanding of what's going on in the hip lumbo-pelvic complex. Go through mini evaluation process and some corrections that I'll be able to hopefully demonstrate, but mostly walk you through, and I'll probably help Dr. Smith he'll be my mannequin as he walks through here. I'll probably feel like a ventriloquist at times, a puppet master, because I'm just going to walk him through some things. But anyways, we'll go through some demonstrations in lab and then wrap up. So full disclosure here, I am trained in basics of sacroiliac mobilization from Great Lakes seminars. This was a course developed by Patrick Hoban. I strongly recommend it with using muscle energy. Great course, great understanding of the anatomy, and helps with a lot of these entry-level strategies for observing and then correcting hip lumbo-pelvic asymmetries. I'm trained in the Mulligan concept for the upper extremity. I know you're like, well, this is lower extremity, Andrew. What are you talking about? Well, I just put in that full disclosure. I've not taken the lower. However, I like to learn. So I picked up the textbook from Brian Mulligan and his group in New Zealand, and been investigating more and more on how to use the Mulligan concept in the hip lumbar complex region. I've spent, by now it's over 5 years, integrating Mulligan techniques and muscle energy for hip corrections. So I have some clinical skills and street cred to apply to this presentation. That's one of my pet peeves. If you're not using it, then you probably shouldn't be talking about it that much. So anyways, I try to use what I'm learning about. A couple more disclosures. I have no financial responsibility or relationship with Mulligan or Great Lakes seminars. We are not here. I am not here to certify you in anything. I'm just trying to drop some knowledge here for you that you can use tomorrow or even today. If you know that you have hip lumbo-pelvic issues, whether it's scoliosis or something like that, degenerative disc, then don't participate in some of these lab items, okay? I don't have a release form for you. I trust that you'll use your knowledge of your own body to participate. All right, so Yes, Houston, we do have a problem here. We have an ACL problem, right? We know that you came here to talk about the hip lumbo complex, but I don't think we can talk that without having a good understanding of why. What's the why behind it? So let me take a couple of minutes to kind of go through some of the issues that we're finding at the knee that could be directed from the hip, okay? What we have here is we have an ACL problem specifically among female athletes, and I'll give you some data that kind of helps support that. And we also specifically have some data regarding soccer athletes. I don't know about you all, but when I was working at the university setting, I had one of our athletic trainers assigned with women's soccer, and it was inevitable. Every year there was at least one, if not two, sometimes up to 3 ACL injuries within a year. Crazy stuff. So I think you can relate to that. So when looking at our college athletes in the NCAA, there's a high incidence rate of ACL tear and re-tear per 10,000 women: basketball, gymnastics, football, lacrosse, and soccer. So this is coming from the injury surveillance program that was published by these folks that were looking at injury rates. And so what they found is that 2 of the 3 highest re-tear rates of ACLs occurred among women's sports: gymnastics and women's soccer. And what they considered an athlete exposure was 10,000 for this study. So what we have here, as we outline, of the ruptures in women's basketball, that was rather large, with the rate of anterior cruciate ligament ruptures by sport. So women's soccer, we get to soccer. So here's gymnastics first. And I'm just highlighting some of these for you, as well as lacrosse. Here's women's soccer. So what I want to point out too is these confidence intervals. So, and these are the confidence intervals of ruptures per 10,000 athlete exposures. Okay, so these are rather large. Look at our recurrent rupture. So when we look at these rate of anterior cruciate ligament ruptures, a higher ratio of recurrent ACL tear in the men's soccer, and the rate ratio is really what's comparing the density of the incidences among the exposed. So a rate ratio of 1 means that there's no difference between groups. And if we get higher and higher, that means that there's a larger kind of a larger rate of the density of instances within a group. So when we look at this, men versus men, or men versus women rather, look at our rate ratio here for basketball. Primary rate rupture, we're over 1, okay? So we're in the 2.6 here of the rate ratio, meaning there's a high density of ACLs. Look at soccer, we have both a significant and high rate ratio. We're over 1 with primary ruptures. But look at women's soccer for recurrent. So there's a high likelihood that they're going to have another re-tear if they've already had one. Moving on, we looked at Joseph et al. And Joseph, he looked at ACL injury rates among high school athletes and found some salt for the wound. So he dumped some more salt here. He looked at athlete exposures of 100,000 athletes exposures. So the previous study was looking at 10,000 athlete exposures. This is looking at 100,000 1,000 athlete exposures. And once again, girls soccer led the way with ACL injury rates. Again, when we look at comparatively, we have this issue between the genders here. We're looking at a rate ratio of 8.8, and that's just like massive compared to, like I said earlier, one is no difference. So we're having some huge issues here with the female population with ACL injury rates, specifically among females. Girls soccer, we look at girls soccer. Here we can follow that along and look at that rate ratio near the end, 14.9. So we just keep climbing higher and higher with this rate ratio. And again, that's like the effect size. It's like how strong is this correlation with women's soccer and having an ACL injury? Looks rather strong. So you may be asking, well, what about if we allow time to help rehabilitate this individual? We're doing our due diligence as professionals. What is it in a perfect world, Andrew, if we say 24 months out, what's that looking like, after a good rehab protocol and a good intervention? I'm glad you asked that. So there are some longitudinal case control cohort study, and this came out here by Paterno. That group was looking at those returning to activity with past ACLRs versus those without ACL injury. And there's a couple of noteworthy items here. Overall, 30% experienced a second ACL within this study, ACL tear. 20% experienced contralateral injury of some sort. And then 9% of those within the study had a re-tear of the ipsilateral ACL. So 3% overall had a second ACL if they already had one in this cohort study. 20% experienced contralateral injury of some sort. So that could have been, in the ankle or hip or something. And then 9% had a re-tear of that same ACL. So, one other thing to point out here is that all recurrent ACL injuries at 24 months were non-contact. So that begs the question, what's going on with the motor control system with this? A couple of things as well that I'd like to highlight: 5 times more likely to sustain an ACL at 24 months compared to males if you're a female. That's pretty staggering right there. If you're female with previous ACL, 2 times more likely to sustain contralateral ACL injury at 24 months. Okay, so something's going on here, and we know this. I think we know that could be just returning people too soon. We're not doing our due diligence potentially with rehab, but again, if we're thinking with the mindset, hey, we're doing everything we can possibly do, these numbers are still pretty staggering.
Dr. Doyle, a question for you. So when these individuals re-tour, can we make the assumption based off of this study that they were they had completed the full rehab and passed all of the normal standardized testing, right? They were completely cleared.
They're cleared. Mm-hmm. Yep. Yeah. And that's part of the issue here is if they're truly cleared, then what's going on here, and that's another discussion for another day, is what we're doing actually good enough to clear people. But what I'm trying to do is build this case that we have an ACL problem, right? And one of the things I think we can do is we need to monitor hip, pelvic, lumbar alignment with some of this. So interesting enough, we were just talking about this as Dr. Smith kind of chimed in here. In a recent SR, systematic review, only 50% returned to previous sport level overall with ACL revision. Let's flip a coin, ladies and gentlemen. That's kind of cool, right? It's like saying to your client, hey, do you want to return to sport? Here's a quarter, flip it. Tails, you do. Heads, you don't. Whether you are involved as a clinician helping them or not. Now, that was a 2015 study, and I've seen these come out enough over the years. It was at 40%, now it's 50%. So we are getting a little bit better, okay, as clinicians. So the other problem that we have with this is that ACL surgery is expensive, right? There's an economic burden to this injury. So the injury alone is significant enough, but it's hard on your pocketbook. So there's also these cost burdens that are associated with this. Not only just with the intervention, but think long-term with your athlete. Or think, I don't know about you, but most of my athletes, NCAA, even Division I, but 2 and 3 in NAIA, a lot of these folks are playing collegiate athletics, and that's about it. I mean, that's where their time runs out. They're not going to go on to professional ranks or semi-pro ranks. So what's the long-term issues? Well, we have osteoarthritis that creeps in. So those are issues that we need to be thinking about, is the long-term. So there are 2 routes, as you probably know, that people may choose for rehabilitating their ACL injury. They can do rehab alone, which is really not standard in most cases, especially in the US with an athletic population. Or you can get surgical reconstruction, which is typical standard with an athletic or physically moving individual, high functioning, physically moving individual. But both are expensive. Mather et al. Did an investigation. They investigated the total lifetime costs of an ACL injury based on these 2 pathways. They determined that with continued treatments and interventions, rehabilitation alone would be most costly, which kind of makes sense. Here's just some cost breakdown from that study by Mather. And so roughly the cost of rehabilitation alone is about $88K, with, get this, 63% of the total cost coming after 6 years. So what's going on there? Well, osteoarthritis, right? Or other complications, okay? Average cost for an ACLR surgery was about $38K by Mather and what he inventoried, and about 27. So nearly 30% of the costs still come after 6 years. So what could be so costly after 6 years? This. Okay, so what's going on there? Well, could also not only the ACL injury, but what potentially caused the ACL injury when we think about non-contact, could hip Lumbo-Pelvic-Complex asymmetries be leading to that a little bit, okay? Potentially. And we know that's going to lead to dollar bills, knee replacement, Symphysis injections, what have you. Whatever's new fandangled medication to pump into that joint or get some pain relief with that arthritic joint. So what can we do to prevent ACL injury? Yeah, I'm sure all of you are thinking, well, core stability, Andrew. Yeah, duh. Sure, yeah, we need to do that. We need to work on core stability. We need to focus on the neutral spine alignment, optimal trunk position, proper load transfer, and then progress from local muscle recruitment to core stabilization with various postures and whatnot. Simply keeping the spine and hip lumbo-pelvic in alignment while undergoing forces of movement is core stability, and that's defined by Blyven in 2013. I really like that definition. So we know that we need to do that, and we're doing it. But it also encourages us to follow down this path of neuromuscular control. We've got to have control of this in different positions, okay? So here's a study by Zazulak. He was looking at the trunk positioning and those that may have had like poor motor control due to low back pain, and could that predict knee injury? So looking at specifically how the trunk functioned when we kind of took out the support system of the lower extremity on a flat surface. And I have a picture of what they kind of did here. And they were looking at 277 college athletes and baseline tested and followed them for 3 years longitudinally to see what happened in relationship to their trunk stability and motor control of their trunk. So here's kind of the apparatus that they used. They put them on this kind of platform here, kneeling on this. And what they were trying to do is they wanted to see if they could measure trunk sway. And what we're trying to see, or what they're seeing, is from an anterior to posterior coordination of the trunk and a lateral movement of the trunk. And so they used this random kind of magnet that was pulling and tethered to their body, their trunk, and then they randomly released that. And then, okay, what did it take to correct? And they also looked at the distance of how much they swayed. And so does everybody understand what I'm talking about here? They're looking at trunk movement, and you know you need to have that core stability within that trunk to maintain in proper hip lumbo-pelvic alignment and stable. So this is what they found here. We've got 2 charts. I hope you can see that well on your screen. If we're looking at the one on the left here, white shaded is uninjured athletes, darker shaded is injured athletes. And so the amount of displacement was significant in that trunk movement that predisposed, or was, I shouldn't say predisposed, that was correlated with a knee injury, a ligament injury, and specifically an ACL injury. So as you can see, the more displacement that was found with their ability to, or rather inability to control the trunk movement, they showed that they were potentially correlated with ACL, ligament, and knee injuries. Okay, and those were significant results. On the other side of the chart here, we have deficits in neuromuscular control that still predict a knee injury. And so what we looked at here from their study is that they were looking at specifically females versus males alone. And so on the left 2 brackets, we have uninjured females and we have injured females. We had they found a significant difference in the displacement, the amount of displacement that those folks had, and it was significantly correlated with an injured lower extremity within the females alone. When we looked at males, uninjured versus injured, there really wasn't that much difference. Look at that; those bars are almost flat line, right straight across. So what this is telling us is that motor control has an effect on the lower extremity. Okay, so I think we have a good understanding of that. Here's just a breakdown of their data that they came up with here. The odds ratio. Remember the odds ratio? It's at strength of prediction. Okay, you know, one is that there's no difference. And as we climb up the ranks here, we can see how strong. So with that being said, you know, when we have something that has this large amount of odds ratio, we know that there's a strong correlation between these 2 things. And the concordance here, as you see that concordance percentage, that's how reliable the item is at predicting the outcome, okay? In this case, it's the accuracy of the displaced movement that they found within those subjects, Okay, so the amount of displacement can also help predict an ACL. So the more movement they had, we know that they had a ACL knee or lower extremity injury. And it was at 70 to almost 78%. If you look at for that ACL, that means that with that movement that they found, it predicted it 78, almost 79%. If we wanted to make the big stretch, 80% of the time, 80% of the time is going to be correct at predicting an ACL injury. Now, it'd be great if you could just set that up as a pre-screen, but who's going to, be able to do that with the technology and the time? But this gives us an idea that that motor control is a huge predictor for ACL or lower extremity injury. As we go through along these columns here, again, injured female athletes showed that specifically just female athletes, 83 concordance, meaning that what's the likelihood, the percentage of it actually occurring, 83% with that large displacement that we found in females, specifically to opening a door to an ACL injury. I mean, that without getting 100%, that's pretty high. Okay. Injured male athletes, again, they weren't out of the woods either. So if you had a male who was injured, they found that their trunk sway, the amount of trunk sway, was highly associated with ACL injury. So there you have it with some of that information. And again, that concordance is a prediction reliability. How reliable is that prediction? Well, it looks like trunk sway is pretty reliable indicator for ACL injury. So with this, we're looking at a regression analysis, specifically just by gender. Female athletes, again, we're looking at the odds ratio, and that odds ratio helps us understand the strength of association. And so again, we're still looking at the trunk. So that lateral displacement of the trunk, how much did it sway and how far did it sway? We're looking at relatively high odds ratios with that lateral displacement associated with knee and ligament injuries within females. History of low back pain. Well, hip, lumbo-pelvic area. Well, that's what we're talking about. I think that's going to be some of the areas that we need to be looking at as clinicians to help predict and potentially prevent ACL or knee injuries. So just having history of low back pain alone among females, that odds ratio, again, look at how high that is. With our males, history of low back pain with ligament injury, still relatively high within our males. So again, females seem to be more associated with it, but that doesn't mean males aren't either. It's just there seems to be a stronger connection with females in low back pain and hip pelvic alignment and potentially displacement, motor control issues that lead and predispose to knee injuries than their male counterparts. And here you can see it was statistically significant when we're looking at the overall items of these things with our female counterparts. Low back pain is always an issue. So that's one of my go-tos. When I start to have my patients and clients come to me with complaints of low back pain, I tend to start going towards hip lumbo-pelvic-complex for number one, observation of asymmetries and then correction. And so we're seeing this, it's connected with ACL. So maybe that's something that we could potentially cut it off at the pass, so to speak, with observing and treating appropriately with manual therapy to get proper alignment to prevent potentially some of these ACL injuries. And so this is a little schematic that I kind of think through logistically in my brain as we talk about this issue. I think we could initiate this cycle at any one point of these three openings, whether it's the pain due to trauma, whether it's in the motor control, or positional faults. Positional faults is just, we have something out of whack, out of alignment. With altered positional faults, this could cause trauma, could cause pain, dysfunction. It could also cause altered motor control. And so you see this cycle. Or maybe poor motor control could cause trauma, could cause pain, and eventually lead to changes in bony alignment. So any one of these components, if it's out of balance, could cause the other to occur, if that makes sense. We're in this kind of wheel cycle, okay? I can only speak for myself, but I think I'm pretty good at addressing the trauma and pain portion of this cycle. I think that's pretty inherent of what we do as athletic trainers, especially those that are early in their careers. I think we do a lot of good with that in educational wise, but I think that I'm getting better at the motor control part of the cycle. Still needs some improvement there. But I feel like I really can improve upon evaluating and treating positional faults. So it's my professional opinion that we start looking at this once we address pain and trauma. So that could almost be secondary. Once we address pain and trauma, now start looking at positional faults and try to correct those. So that we can engage the motor control activities effectively once everything is properly aligned.
Dr. Doyle, a real quick question on that, just for those that are watching. When we're referring to positional faults here, are you referring to dynamic stabilization, so things aren't moving correctly as the person moves, or are you looking at prior to moving, having the optimal efficient environment?
Static first.
Yep.
If that makes sense.
Yep.
And then I think that's a great thing to segue into if we had more time, is like, all right, now while they move, does that move correctly? Or does it go faulty again with that alignment? I don't go into that, but that's a good point to make. I hope I'm making sense to all those there. Okay. So we could, once we take the pain out, that's great. We can do that. Motor control, maybe we don't get to there quite yet, but this positional faults, something that we need to address, whether, in this case, statically, get those corrected first. Because what we don't want is to just jump right into motor control. In my opinion, if we just get pain managed and we start now motor control, start influxing the motor control system with stimulus, what essentially could we be doing is, if we have poor alignment, we're not getting correct firing that needs to take place. And so what we have here is, it's like taking that new car, you just invested a bunch of new tires in the front end, but you didn't do a front end alignment first. And so what happens within 2 months of driving that car, you get a bald spot on one side of your tire. It's putting new tires on a faulty aligned front end of a car. We got to get alignment first. We got to get some static alignment first before we start influxing with motor control. We know it's needed, but we got to get things aligned first, I believe. Does that make sense?
Yeah, that's great. I love that analogy too. I'm totally stealing that from you, and I got to use that in class. That's right. Perfect.
Just send me a dime. All right. So we learned that low back pain is associated with knee injury, but how? Okay. So a couple of things here, and this is really basic level, and you're gonna be like, well, duh, Andrew, yeah, we kind of know this. Okay, well, let's start doing something about it. So there is an incidence of foot rotation with pelvic crest leveling that we need to take account for, that also says that there's a relationship with back pain. Okay. So those with pelvic unleveling from this study by Houston in 02 said that recurrent back pain was 77% specificity with a 90% positive predictive value. So that means when it was positive, it was 90% of the time correct with looking at pelvic unleveling. So there's an association there. So that means, you know, with one pelvis ilium higher than the other, we should probably correct that because it's associated with low back pain. We know low back pain is associated with ACL tear. So we got to correct that and bring that even in order to then start engaging motor control activities. Recurrent back pain was 70% specificity with a 90% positive predictive value with that pelvic unleveling. We also see that when we utilized a correction for an anterior tilt that was found in this study of individuals with low back pain, it improved Cobb's angle. And so Cobb's angle is this, it's a resultant measurement of the most displaced proximal and distal vertebrae, usually used to determine scoliosis. And so of this study by, again, I'll go back, Jung-Hoon Lee by Lee, this was a low-level evidence of relocating the anterior tilt. And what they found is if they relocated the anterior pelvic tilt, they improved Cobb's angle. So once they corrected this, we are doing something to make change the biomechanics of the lumbar spine just by addressing the pelvis. And so we know the pains associated with ACL, we need to be looking at how we align the hip lumbo-pelvic. Okay.
Another follow-up question for you on that one. Do you know if that was so, just because your title's covered up here, was that done on healthy people or was that done on people that were diagnosed? Okay, we got SI joints.
Case study.
Okay.
Individuals with pain or a individual with pain. Does that help you, Darren? Did I answer your question?
Yep, thank you.
Okay, all right. Yeah, so this case actually was a swimmer who complained of low back pain in the buttock as well. Low back pain and butt pain, okay? So you can see the changes. The before is on the left, and then the after is on the right. And so what we're looking at, I don't know if you can see my cursor here, see my mouse floating around. All right, so we're looking at the most proximal displaced vertebrae with the most distal. And so we're looking at this angle here in relation to this angle here. And so you can see this angle shrunk quite a bit just by looking at it clinically here on the x-ray, and as well as did angle A comparatively at the post. So we are doing something biomechanically with just correcting the anterior tilt. If we're getting the tires, if we're getting the front end aligned, you know, what's that going to do with our tires now, our knees, right? We're going to do something, and it's also going to allow us to apply motor control appropriately. So if pelvic alignment could be associated with LBP, could LBP alter motor control? Potentially. Could altered motor control alter movement patterns? Potentially. Could altered movement patterns create injury elsewhere in the system? Potentially. Okay. Hodges proposes that the current pain and past pain can influence how muscles are recruited and the order in which they are recruited. The body wants to take the path of least resistance, okay? So current pain and even pain that was in the past, it still has a lingering effect on motor recruitment, timing, and strategy, okay? Even when pain is gone. The only thing, the caveat to this, did they look at how their pelvic alignment, hip lumbo-pelvic alignment looked? And does that potentially change motor control? Speaking about how muscles are recruited, Delp found an interesting tidbit here, looking at the effects of different angles of hip flexion on the angle of pull the glute has on the femur. Delp found that as the femur goes into extension, the glute's angle of pull on the femur is externally rotated. However, as the femur goes into flexion, the glute's angle of pull shifts to more of an internal rotation on the femur. And so this is the question I pose. Would an anterior tilt of the pelvis stimulate an early onset of hip flexion and change the pull of the femur into internal rotation? So with that anterior tilt, we're already creating mechanically some sort of hip flexion, correct? Hopefully you agree with me, and maybe I'm off track, but that's what I'm wondering, if that's potentially could be one of the things that leads to potential ACL tear when it's associated with hip lumbo-pelvic alignment. All right, so any questions or thought on this? The other thing that I would also throw in is if we have an anterior tilt of the pelvis, and if it's stimulating an early onset of hip flexion and changes the pull of the femur into internal rotation, could this further exacerbate valgus load? Also exacerbate internal tibial rotation, also exacerbate navicular drop, and increase risk of ACL injury. Look at that, all that kinetic chain coming through. So we talk about the kinetic chain, but are we really applying it biomechanically to our patients? So those are some things to be thinking about.
That's a great point. Thanks for making all those connections for us. I think a lot of times we we will isolate out, or we have been taught by our books to isolate out certain segments, and then we're not really getting to the actual cause of the problem here. And I mean, you really just linked everything together. But you know, all of those positional faults that you just said, even though we're looking at one movement with all of them, could that be contributing to plantar fasciitis? Could it be contributing to shin splints? Could it be hip flexor problems? We
don't steal my thunder, Darren, because I have like 3 cases that I'll outline at the end here.
I'm gonna shut my mouth. All right.
I love it. Yeah.
We have a question here. Go ahead.
Yeah.
So with all those positional faults, do you think too then there's obviously improper firing of the glutes because you're?
Could you repeat that for me, Darren?
So with all the positional faults that you just went through, so do you believe that causes abnormal timing? Did you say?
Firing of the glutes,
yeah.
I think it can.
Yeah, because they're put in a more lengthened position.
Yeah.
So that alters things.
Yeah, so with this study by Delp, he used cadaver models. So he took a cadaver and he was looking at different hip flexion and he computerized it. So someone way smarter than me, way above my pay grade, who figured this out. But this is what he found with it is if we position the hip into flexion, the glute, when fired, actually had a mechanical difference in how it pulled on the femur into more internal rotation. So with that positional fault, potentially, because what I'm saying is the positional fault of an anterior rotation of an ilium, we're creating that flexion without bringing our hip up. We're actually creating that. And so with that being said, that positional fault potentially, I don't have high evidence indicating this, but if we have that anterior tilt, we are predisposing that femur into just whatever it's millimeters or whatever centimeters of hip flexion before it should take place. And so now we're potentially altering the motor control pattern through the glute. Did I address that question?
Yeah, yeah. And I like how you also talked about the positioning of it, but then also the timing of it, because I think we also get hung up quite a bit on this is not activating, but it's activation is really relative to the task that you're going to be doing and when it's taking place with the synergy going on.
Yeah, and that's the thing. If you're a clinician who can figure out how to do that really well with the timing, you'll be making dollar bills all day long. So figure that out and help me so that I can learn from you. I think that's going to be the next phase of our profession is, okay, how do we know there's positional faults, corrected, bingo. Okay, I know I can practice with motor control. I can do some things with motor control, but for recruitment standpoint, but what about timing of it appropriately? We're talking like EMG, we're talking, surface, but also embedded EMG, potentially how to understand the timing behind it. I think that's still yet to be discovered and really have a good grasp of it clinically. So I'm going to move on here if everybody's good. Any more questions here before okay. Back to my flow chart here. So this got me to thinking about a PICO question and a PICO question associated with this talk. I think we need to look at resetting the positional faults and then focus on the motor control aspect by strengthening and muscle re-ed and proper timing. We know we have an ACL issue. We know that we are not doing the greatest of jobs getting our ACL patients back to pre-injury level. We know that many athletes are re-injuring their repaired ACLs. We know that we need increased motor control to prevent injury, but I think we need proper alignment prior to properly engaging the motor control system. Blyven says motor control helps sustain proper spinal alignment. So shouldn't we make sure we have proper alignment to begin with? That's where I'm coming from. So what we are dealing with is this. We're dealing with this right here. You guys have seen this in textbooks. You've seen Dr. Smith talk about it. He talks through this in his biomechanics class and more in depth than what this little picture shows. But you guys get the idea. Do we want to strengthen something or invoke motor control of something that looks like this? I hope we're seeing a lot of head shakes. No. All we're doing is throwing that new tire on there and it's going bald on the outside or on the inside. We've got a poor alignment. We got to address the alignment issue first and then start activating with our neuromuscular skills. Okay. If we correct this pelvic alignment, would we see an improvement in ACL tear rates among our female soccer athletes? Potentially, I don't know. I'm thinking as I follow the evidence a little bit, I don't have cause and effect evidence to provide that information, but I have some things that I'm drawing on that could lead to that. So if we simply even correct an anterior tilt, that decreases low back pain, that decreases the influence the glutes have on internal rotation, that decreases motor control deficits, improves the functional and anatomical alignment, and improves ACL prevention potentially. Everybody following me?
Yep, we're good.
Okay. So this got me looking at this picture. I'm like, all right, I'm staring at this in my head as I'm going to bed at night, sleeping. I'm looking like, look at this navicular drop. Look at what anterior tilt could do to the navicular just by simply looking at this little diagram, okay? So navicular drop, it is associated with ACL injury. And this was a study done a long time ago when I was, just a young guy. Beckett in 92 looked at this. So what this did, what they discovered was that induced hyperpronation did not significantly change pelvic tilt, but The shank internal rotation was associated with pelvic alignment. So the actual shin started to move to compensate for that. And that's what then drove this navicular drop. So it may even skip a joint, you know, isn't that crazy? It's just interesting. All this background information to get us to this clinical question. Does a routine pelvic alignment prevent ACL tear from recurring among female patients with previous ACLR? Okay. You kind of got to see into the warped mind of Andrew Doyle of how I got to that point. So it was a long road, but we finally got to that. So I did a little search, okay? You can see kind of my search criteria here. Search these three, so not like a huge robust search, but these three main players in our research world of physical medicine. And you can see what I found here as far as the articles. Look at that. None of these studies met the inclusion exclusion criteria. How wonderful. Dead ends. Okay. So that's why I had to kind of give you that background. So now what? Well, look for prognosis evidence investigating the association of hip, lower extremity biomechanical factors, and ACL prevention. So that's my charge to you guys who want to be researchers. Help me with this. Okay. These have limitations due to retrospective nature and extrapolation. That's the problem with some of these things when we're looking at prognosis evidence, when we're following a cohort. There's other confounding variables, okay? There's always going to be limitations with cases versus control group formatting. All right. So I'm still on my charge to try to make use the evidence to give me the best information as I go through this EBP question. And so what I have here is two prognosis case control and cohort studies. And this is what I found from Hurdle and Loudon. So Hurdle, he found that both navicular drop and anterior tilt increase the odds of having an ACL injury 16, 20, and 5 times. Okay, that increased the odds of having an ACL injury by 16 times, 25 times, 5 times. Don't know for sure if these malalignments are from trauma to actually trauma to the knee or precursors to the trauma. Because we were looking at, they were looking at those individuals that already had a history of ACL. So did they have that already, or was it because of the trauma itself to the knee? Does that make sense? So there was a relationship with having navicular drop, Q angle change, differential, short leg, hip internal and external rotation, pelvic tilt, all those things, hip lumbo-pelvic-complex items for the most part, and they had a relationship with ACL. So here you can see that within the data, navicular drop. These are means and standard deviations. Injured limbs, look at that. Significant value over there in the right-hand column. Navicular drop, innominate rotation. So like an anterior rotation. Okay, statistically significant with association with injured limbs. But again, we don't know if it was because of the injury itself or was that there before the injury, just because of the study design. Again, looking at navicular drop odds ratio, look at that odds ratio. The strength of association with navicular drop was significant and it was large. Look at that, 20, 16, craziness, okay?
Dr. Doyle, you were saying one is no change. Could you kind of give us an idea for those of us that aren't familiar with it? When you start to look at that number, is there something that maybe these students should be looking at saying, okay, when does this number, when is how high above 1 do we need to go before this really starts looking like, holy cow, I better pay a lot of attention to this?
Okay, I like that question. I'm gonna have to dig back into my slides. So if I could do that at the end, because I have the odds ratio kind of like what's weak, strong, or weak, moderate, and strong, if that makes sense. But that's embedded deep into my notes of my slides. So or we can, you can like do a simple Google search, because it's basically like looking at Cohen's D and also effect size. They're very similar with what the odds ratio is. And so the odds ratio does have like parameters of like, generally speaking, what's low, generally speaking, what's moderate, generally speaking, what's high. Okay. Those numbers are not ingrained in my head. I have to look that up, but I have it in my notes here. But if you would allow me to do that at the end, that would be great. Just remind me.
Yep. Thank you.
Yep. Okay. Where was I? Oh, anomalous rotation. So, some kind of rotation on the ilium. Again, if it was greater than 3 degrees, almost 4 degrees, we had a significant association with that ACL. So kind of leading back to the hips here. All right, so moving on to the Loudon study that I pulled that kind of was close to what I was looking for. The relationship between static posture and ACL injury in female athletes. So this categorized 20 ACL patients based on the level of severity for 7 biomechanical measures. Participants were looking at their injured leg compared to their non-injured leg. So this placed injured knees and non-injured knees of the same individuals into categories based on 7 criteria of biomechanical alignments. They ran a chi-square test to see where the distribution of these items fell in the categories. So anterior pelvic position, navicular drop, and subtalar joint position were found to have significantly high, almost 2 times as high between the injured legs and the non-injured legs, meaning that these variables were strongly associated with the condition of an ACL tear. Again, those items were anterior pelvic position, navicular drop. Right here, I have that circle here. And so they just kind of blanketly, what's a high value and low value? I can't remember exactly what their criteria fell in for a high value or low value, but as you can see from the previous study that I just showcased, like they were looking for an anterior tilt of like 3 or 4 degrees is what they're finding in some cases. So anterior tilt could be a high indicator for ACL injury. Pelvic positioning. Pelvic positioning was a significant driver for these individuals with ACL injury abnormalities. Okay. Sagittal knee position as well. And navicular drop with that subtalar position. So clinical bottom line here, a recommendation here, there appears to be grade D evidence supporting the current PICO question. So not really great evidence, not strong evidence, not consistent evidence, because like I said, I didn't find any kind of cause and effect type studies. So very low level. This grade is assigned due to using a lot of case control studies to answer this question. And so that when you use case control studies, that allows for extrapolation from the reviewer, me, the reader in this case. And so that I can bring in my own bias into that a little bit easier, okay? So, but bottom line is there is a need for inception cohort studies. So meaning they are coming out with the intent to look at these markers of the hip pelvic alignment in ACL, or a hip pelvic, the intention to align and keep aligned the hip pelvic lumbo portion of the body and follow and track ACL injuries throughout the course of a season or several seasons. because we'd like to understand more of the risk ratio when we actually intervene with a hip-pelvic lumbo alignment strategy. See if that intervention actually limits the prevalence of ACL tear. That's where the research, I think, could lead to dive into a little bit deeper. So that's my warped brain and how I get to this and why I feel like this is important. Anybody have any other questions before we move on to more of the fun stuff?
No questions here. Could we take like a 5-minute break?
Yeah, we can take a fiver.
Okay, I'll pause this here.
All right, so we've gone through kind of like the understanding of why we need to look at hip lumbo-pelvic alignment based on what we're finding with the ACL injuries and the prevalence of such. So let's dive into now, let's observe that's correct and go through some of the strategies that I've learned over the years. So terminology, let's just kind of go over terminology real quick. If you see like Mulligan, some people will kind of like not call it Mulligan. They may call it like mobilization with movement. Chances are it's still going back to the derivative Brian Mulligan. He created the technique of the Mulligan technique, for his namesake. But it's basically we are using movement while we address some kind of positional fault. Okay. It uses a combination of osteokinematics and arthrokinematics to help correct those positional faults found. Positional faults could lead to altered movement of pain and pain and altered movement and then pain and altered movement and pain, so on and so forth. Or it could cause pain and then altered movement. So we know that's that vicious cycle that I talked about earlier. Where do we jump into this? Typically we address pain, and then what I'm suggesting is instead of going right into motor control, make sure that everything's aligned first and properly, then address motor control. And so we use mobilization along with movement. Just a second, I'm having some technical difficulties on my end here. My slide is not advancing. There we go. All right. So muscle energy technique, on the other hand, it's a manual treatment utilizing voluntary muscle contractions to correct the alignment issue that you observe. Basically, the clinician uses resistance to assist the voluntary contraction torque within the muscle. The resulting muscle contraction causes the positional faults to be corrected. So there's still muscle contraction along with, if we were to do a Mulligan, there's also muscle contraction. So what's kind of the difference? Well, I mean, all roads lead to Rome. So you may want to use other techniques, but these are some of the techniques I've kind of utilized in my clinical practice that are very beneficial to help some of these malalignments that we find within the hip lumbo-pelvic complex. So as athletic trainers, we often use movement in order to correct, whether that's muscle contraction movement to move the joint or the bone that needs to be realigned, or we actually have them move through range of motion where there's still muscle contraction. So they're really very similar broadly in nature, but understand they're similar because the goal is to get correct alignment. Okay, and we're using movement or muscle contraction or both in order to do that. Key anatomy, let's look, first things first, let's keep that. We need to know our eye dominance and make sure that you know your eye dominance. And have you all, used the little diamond feature, look at something, put something squarely in the center of that triangle and line it up, and then close one wire or the other, whatever maintains that in the center, that's your dominant eye. I'm assuming you've kind of done that before in some of your classes. Dr. Smith, are they kind of aware of how to do that?
Yep, we're good.
Good deal. Anatomy, you guys know your malleoli, okay? Medial malleoli. And so what I advocate is once you find this, instead of resting right on top of the medial malleoli, come right below it. So once you get on it, roll right off of it, like immediately off of it. And so that helps you kind of say a standard of that's where we are. Because if I'm here, am I up high, am I in the middle, or am I low resting on it? So entirely slide right off of it, okay? But you're right underneath it. Same thing with the ASIS. ASIS. So we could either be on it and that can skew your observation, or we could be a little bit high, or we could be a little bit low. So come on it, slide immediately off into the soft tissue, right immediately below it. Okay, that's one of the things that I advocate for. So hook your thumbs right underneath it. Iliac crest. When we palpate iliac crest, do not come superior down to inferior. Come inferior up. And the reason, like, if you're like me and have a dad bod, I've got a lot of insulation around that area. And so if I come down, I'm pushing that adipose tissue right on top of the iliac crest. We don't want that because that could skew our visual observation. So we want to come up by the greater troch, slide up until we immediately feel like we are curling right on top of the edges of the iliac crest. That's just another kind of strategy that I advocate for. PSIS, dimples on the back. And so with that, we are following the iliac crest all the way around posterior until you find that nodule or dimple within the low back, just inferior and medial to that. Sacral basis. Once you're on the PSIS, so take like the joint of your thumb, and once you're on the PSIS, I want you to rotate 45 degrees up towards the head, and then curl your fingers in, and you should be right about where the sacral base is. And that sacral base will give us an idea of depth of, do we have a forward flexion, potentially extension, or torsion, okay? I'm not gonna get in too much with evaluating torsions like, this is our sacrum, a tilt like that or a tilt like that. We'll mostly just kind of focus on forward flexion or extension of the sacrum, okay? But that's how I advocate.
Yeah. Dr. Doyle, these guys are familiar with all that terminology, so feel free to use whatever you want.
Awesome, good deal. So now that we know some of the bony and lime processes that we need to locate and identify for visual observation, this is something that Patrick Hoban has come up with that I have really taken a kin to, that really helps devise a system of correction. And he says that if you use this system, some of the things higher up on the category of correction within the system may correct some of the things that you may find later in your progression. Does that make sense? So there's an actual reason why he says, do this first, this second, this third, this fourth, this fifth, because some of the things that we did first and second may help correct some of these things underlying that are lower in the hierarchy, okay? And he has come up with this acronym called PUFFERS, okay? And so we want to also use the Wilson-Barstow maneuver to help reset the hips as we check all of these areas of the PUFFERS acronym. And I'll get to the PUFFERS acronym here in a moment. So we use the Wilson-Barstow maneuver, basically that pelvic bridge, okay? One thing that I will say, when you're doing this, make sure feet are flat on the table, knees are bent, and one foot is not like ahead of the other or behind the other. Make sure toe to toe. Make sure their feet are together, and look and see how they bridge up. Some bridge up, with their heel and they lift up their big toe. Say, hey, no, plant your whole foot, forefoot and all, into the table and bridge up. Okay, that's going to help recruit the glutes that should be in order to produce the movement the best. So what's this acronym look like with PUFFERS? Okay, number one, P, pubic symphysis. That is the first thing that we correct, okay? I will say a little sidebar here, depending on what your client is comfortable with, this is something that I don't clinically observe a lot of times, especially in my world where I'm treating a lot of female basketball athletes, tennis athletes. I'm not going to go and invade their space, okay? However, with that being said, that doesn't mean I don't still correct it because it's high on the hierarchy, right? So I'm still going to correct this. And without even observing it, because most of the times if there's something else going on with the hip and pelvis, the pubic symphysis is probably, off some sort. Okay. So I'm still going to correct that regardless. Next item in our acronym and progression is we're going to look for upslips or downslips. Downslips are really rare because when we walk, that can correct it. Okay. We become gravity dependent, that can correct the upslip, the downslip. But we are also going to observe for upslip, and this is what you're traditionally going to be correcting most of the time. Then we progress into the flares. Is it an outflare or inflare? Okay, that's our next go-to. So after pubic symphysis, after correcting and observing for upslips, now we get into the flares. So the flares, the ilium is flared out or inward, depending on what's going on there. I typically see a lot of outflares is what I see. And then rotations, either anterior or posterior ilium rotations or anterior tilt. The S is the sacrum and the lumbar. However, with going straight to the sacrum, you cannot really get a good correction on the sacrum without first addressing the lumbar. So you need to address the lumbar prior to the sacrum. And this is all from Hoban, okay? Okay, so we need to look at this. We need attribute. So let's look at evaluating this hip using some of these techniques here. So Dr. Smith, if you have someone that we can maybe utilize in class with your other camera, we can start kind of going through this PUFFERS acronym and what that looks like.
Yep, absolutely. We have someone here that actually currently has SI joint pain. Okay. So how long have you had it for?
3 months. I mean, let's go with November.
Since November. So it's chronic, right or left side? Left side.
Okay. All right. So we'll give it a whirl. Let's take a look at this. And Darren, if you'll be my eyes and hands while I'm teaching through tele-ed, that'd be great.
Yep. Okay. So you'd like us to start with her laying down supine then?
Yep. If you want to, I don't know, move your camera over there so I can kind of see what's going on, that'd be great. Cool. All right. So first things first, before we get into any kind of observation, we want to have them perform the Wilson-Barstow maneuver as best they can. If they are in so much pain they can't do it, then you can actually help physically lift their hips up as long as they're in that hook lying position. Okay. So make sure those feet are squared together. We don't have anything funky out of line there at the feet. Okay. And this is also a good time to observe any kind of tibial length, femoral length. Okay, you just need to do once. Now, we're just going to do once. Now down. Okay, and then now what Dr. Smith will do, he will passively extend. So only allow the clinician to do this. What happens sometimes is people want to just shove their feet out, and that's really on the clinician to do. Okay, so you need to communicate that with your, and yeah, a little tug like that is just fine. Just be careful of how much you may correct an upslip in unintended. So we can look at the malleoli down there for alignment. Again, we're hooking right underneath the malleoli. We're looking at the level of the thumbs between there. And so it's really difficult for me to see, but you're looking to see how straight across is your thumb with one another as you hook the malleoli. And so I usually start there and look. So let's go up and we'll adjust this pubic symphysis because that's the first item that we do with our correction strategy. Now, again, since my client and I, we probably aren't going to investigate exactly that pubic symphysis relationship with how that looks with anatomically observation, but we can still correct. I will say, barring just the pubic symphysis, we correct what we see. This is the only one that I always correct, regardless if I observe it or not. And so what we do here is that we have them spread their knees apart as long as they're comfortable with that. And we put I like to put my arm, my radius and ulna right in between the knees. And so what we'll do here we'll use a muscle energy technique to correct this. And what we'll have them do is contract. We'll bring their adductors, bring their knees together, hold it for a 6 count. 1, 2, 3, 4, 5, 6. Relax. We can do this, cycle through about 3 times. So go ahead and do that again. Contract. 1, 2, 3, 4, 5, 6. Relax. And go ahead and do it one more time. 1, 2, 3, 4, 5, 6. Relax. Now, as I'm doing this, if I'm Darren, I'm also trying to pay attention. Does one adductor seem to fire more than the other side? And I don't know if that was the case with her. Did you notice anything like that, Darren?
She's stronger on the left than the right.
She's stronger on her left? Okay, so go ahead and come out of there. And so what I'll do is here, stand right there where you're at, Darren, and have her go into that position here. And on the left side, I'm gonna, okay, spread your knees apart again. I'm gonna use my hands now instead of my forearm. And so as she's doing the actual knees together, on that left side, I'm gonna perturbate it just a little bit. And I wanna actually engage and wake up those adductors with a little bit of stretch response. Okay, does that make sense, Dr. Smith?
Yep.
So you could do that as well, because we want to get that adductor firing a little bit. We want to wake it up, okay? So again, you do that for a 6 count, and you're just kind of perturbating that left side. You said that left side was weaker?
Left side was stronger.
Sorry?
Left side was stronger.
I'm sorry, then I correct. Right side, do that to the right side, that perturbation. Perturbation on the right side. My apologies. And so we do that until we feel like, all right, this is leveling out, all right, as far as motor control wise, okay? All right. So even though we didn't assess the observation of the pubic symphysis, we are going to correct, and we just did that. So we can do that on the shotgun technique. If you want to take a couple moments, go ahead and try that with a partner on a table. I'll give you about 30 seconds, okay? 30 seconds.
That was great, Dr. Doyle. She could feel the difference after about 3 rounds of that. She locked right in with that right hip.
Good. Yeah, if she just hangs out there, that'd be great. I don't want her moving around quite yet.
Did we get a cavitation there?
Yeah.
Okay. So the next one, so we can call that the shotgun technique. I'm sure you're familiar maybe using that. But again, this is a protocol. This is a step-by-step thing that we're utilizing. So we want to kind of go in this pattern. So the next one we have is, of our puffer, PU, is the upslip. We want to check the tabletop, okay? And we can also check the median malleoli. So just because the malleoli might be off doesn't mean it's automatically an anterior tilt. It could be because the ilium is upslipped. That can cause that. So we can't always just like say, oh, the malleoli are off, so that means this. We still have to investigate appropriately. So when we palpate up on either side. And so what I would do is I'd have her bridge up again, Wilson Barstow. Okay, go ahead and bridge up and down. Now passively take her into extension. Now what I'm going to do is I'm going to try to align my vision right over the top of her pelvis and look and see where the ilium upslip is, if one exists. So I'm palpating more distal as I come up laterally to the top. And I'm holding my hands just like the picture shows here on my slide, as I'm just putting my hands right on top. Now, you got to be careful that you don't go like this with your hands. We want to make sure that your hands are flat and level straight across. And so we're using our dominant eye here to make sure that we line up and we try to see, is there one higher or lower than the other? Okay.
So the right is higher than the left.
The right is higher than the left. Awesome. Okay, so we're going to be working on the right leg here, okay? There's a couple ways that we can utilize to correct this upslip, okay? So on the right hip, we can use the muscle energy way, or we can use the active kick away, okay? So the muscle energy way is we would take that right hip at the ankle, okay? And we swing that out into about 30 degrees abduction. 30 degrees abduction, and then we internally rotate the hip. So internally rotate, grab with both hands, internally rotate. Okay, we want to really lock that acetabulum and femoral head together. And so this is gonna give us a closed packed position, okay? Now, we can apply just some static traction. So Dr. Smith, if you just want to lean back a little bit, pulling on that, you can. As long as we have 30 degrees abduction and internal rotation of that hip. And we can hold that for about 6 seconds and then relax. We can do that a couple of times, couple of reps. And I usually do that about 3. The magic number here a lot of times is about 3 times. Okay. Sometimes this will correct it, especially in my females. Now, having said that, for those that might have stubborn kind of QL, I advocate using a positional release technique to release that QL, but we don't need to get into that today. So Dr. Smith, I want to give you the muscle energy way. So get in that same position, 30 degrees abduction, internal rotation. What you're going to have your patient do is on the count of 3, they're going to forcefully cough. So what that does is it allows the diaphragm to contract and maintain a contraction on the pelvis while you pull, okay? As you, on that 3 count, Dr. Smith, your objective is to do a short, powerful traction, okay? It's dynamic, okay? So as they cough, you're doing that. So it's a timing thing, and it's a forceful, quick movement. So, and here's the other thing. Describe to your patient that the cough needs to be a single big smoker cough, big smoker cough like that, okay? None of these wimpy coughs, all right? As you have them cough, that's where you're timing your traction pull that's forceful and dynamic. Okay. So we do that 3 times. So whenever you're ready, Dr. Smith, get in that position, have your client cough on your number 3 count, and on that cough and 3 count, you are applying that dynamic traction. One just swift movement backwards, okay?
So I'm going to say 1, 2, 3, then cough. Okay. So cough after 3. Yep.
All right, so you guys are all on the same page.
I just want to see how much kind of pull.
Abduction, internal rotation, that's important here. Abduction, internal rotation. And it's just a swift movement.
Okay. 1, 2, 3.
Oh.
Yep. And you can do that up to 3 times. So what I would do now, since you've already applied some traction, we'll go to the next one. Does everybody see that, how that was done? Yeah, go ahead and examine that. And where you finding with that right side that was up?
We're even out.
Awesome. So with this one here, this is the active kick away. I really like this for if I have a stubborn one. You don't need to do this like you normally would. Maybe use someone else right now with her instead of her. So if we can move the camera to another individual, hang out there, young lady. What's your name?
Miranda.
Miranda. If you can just turn your head to watch what Darren does here, where I coach him through. Just hang out there for a minute, okay? So Darren, can you get another student and just move your camera to that?
Yep. So we'll get on another table here for you.
The active kick away. This is this next one. This is a good one that I typically use too, and a lot of my runners. And Darren, if you don't find an upslip, just be careful of what you do here. I trust you. I mean, you're not going to go crazy here.
She's also on the right.
Awesome. Okay, so right leg, we're going to do an active kick away. So Darren, take that right leg into hip flexion, knee flexion.
How much?
90-90. Yep, just like that. And so Darren, you're going to be more on the inferior side, okay? Yep. And so what you're going to do is you're going to coach her through this. So you're going to be standing, Darren. You're going to need both hands kind of slid to the ankle eventually. So you're going to passively take her into full extension as it comes in contact with the table. Okay, so passively just take her down into full extension of the hip and knee. Yep. Okay, so that's the movement pattern that we are going to create. Now, this person, what's your name here?
This is Maddie.
May? Okay, so May, he's going to do this 3 times. On the 3rd time, I want you to drive your heel across the room, like you're trying to forcefully push that heel across the room as you come into full extension across the table. Does that make sense? So you're taking this and you're pushing it down and across the table, forcefully pushing that heel towards that doorway that looks like it's behind Darren, okay? That's on the 3rd time. So as she is pushing that, Darren, then you are applying that swift traction along with it. Sometimes you'll hear like the back of the knee slap against the table. That's okay. That's kind of what you want to hear for and listen for as you do that. You can just walk through it kind of gingerly here. So, and then boom, you're pulling. Yep. As it comes in contact with the table. Boom, you pull. Now, on this 3rd one, yep, she's kicking straight. She's pushing that heel straight out. Okay. If you want to try that full go now.
We just did on that last one.
Oh, great. Okay.
Just a little bit higher.
Okay, so now you can try it again here. There you go. One thing that I also recommend is that left leg needs to be in extension. She kind of brung it up like in a knee flexion in order to compensate for the movement. We'd want to shut that down.
We're even.
All right. So we were still able to accomplish the goal, but that's, I don't know if you heard my tidbit, you know, that left leg, we just wanted to hang out there. We don't want it to get involved a whole lot. So 2 ways: muscle energy, 30 degrees abduction, internal rotation, cough and pull. Active kick away is to that one that Darren just showed you there with my coaching. They're just going into knee flexion, hip flexion, and then pushing their heel straight across as they go into extension, okay? So that, and our puffers, we are at the upslip. We can cross that off our list. We can go back to our patient, do a Wilson-Barstow maneuver, bridge up, and passively extend. And now we can look for flares. So now bring them into full resting extension here. A couple areas that we're going to assess for the flare is at the ankle and really the lower leg. I'm glad she did that, because that's kind of a no-no in my world, is that she pushed off to have her scoot up on the table. Always have your patient use their arms to kind of slide their body up, okay? Because what we can do when we plant that forcefully into the table, we can cause an upslip again or a different rotation, okay? So just keep that in mind. Did everybody see that?
Yeah.
Okay. So if you look at the screen here in my PowerPoint, this is a classic example of an outflare. Look at that rotation there that we have. We're rotating that hip, ankle, knee into as a unit outwardly, and we're almost parallel with the table. And in fact, when I took this picture, we could probably just keep on going until it was like negative degrees. It'd be swinging down below the table. She had that huge of an outflare, okay? So this is one of the positions I advocate for checking outflares. Is we need to have, if these are my feet, we need to have 45 degrees of outflare, and we need to have 45 degrees of inflare for a total arc of 90, okay? What happens is you'll see people with outflares and they'll just go boom, straight down like that. And this will kind of like go right here on the opposite side. Inflares, they may do the same thing. They may come all the way in and only a little bit on the other side. So that would indicate an inflare on that side. One thing when you check for inflares especially is the ankle will tend to go like lax, and that may alter your visual observation. Make sure you lock that ankle, okay? Lock that ankle as you rotate. Don't kind of let them go lay loose out of subtalar neutral, okay? Does that make sense? The other thing that we could observe is if we go up to the pelvis and go up the ilium, find the ASIS, and instead of looking for where we put our thumbs for rotation, hook them upwards like the picture shown. And you can visualize, if you take your dominant eye and look at the midline, does one side kind of rotate out more, or is it further away from midline than the other side? And if that coincides with what you're seeing down at the lower leg as they rotate, then that's a good sign, an observational clinical sign for a flare, in or out. Does that make sense?
Yep.
Okay, so let's assess for flares here with our individual, Maria, or Miranda. Is it Miranda?
Yes.
Yep.
Okay. So we can do this at the feet, which I love to look at. I think this just gives me a good idea of hip rotation. And you are passively doing this. You're passively doing this with your client. Again, be aware of that ankle out of subtalar neutral, because that plantar flexion rather can cause a little bit of discrepancy in your visual observation. Sometimes, Darren, and I know I appreciate the angle, but sometimes if you're right up over, you can really see this as it rotates out or inward. And we want to do this simultaneously. We want to do this at the same time with each side bilaterally. So we're taking them and grasping them. You may have to go in a little bit of abduction, Darren, and you rotate inward and rotate outward and see where the range of motion is most, if it's most towards the inward or the outward. Again, be careful grasping the ankle like that. Come a little bit high on the ankle joint itself, almost like anterior ankle joint with your hand, and rotate.
How are we looking there?
That looks pretty good. Like I actually come right on top, hands placed right on top of the lower shin as I rotate. There you go. Now, kind of lock that in there, rotate outward and inward, and compare bilaterally. Oh yeah, that right side there, that looks like it's heading out way more than the left side.
She can feel that too.
Yeah, so it looks like she's got an outflare. Now, we would do the same thing to check for inflare. We would rotate in. Sometimes people with that, especially if she's got an outflare, it'll just like stop straight up and that's it. It won't even go into internal rotation at all. Yeah, that's a good technique right there, Darren, for hand placement. You can check that and then rotate. Yeah, and she comes in a little bit, but not nearly as much as the other side. All right, so what we can do here is with that side, we can do a muscle energy way or a Mulligan way. And so the muscle energy way is, since she has an outflare on that was her right side, correct?
Correct.
Yeah, and we can observe at the ASIS. I like how you got your hand placement. You're right on the medial board of the ASIS, and we're just eyeballing from midline down to see if one's rotated out more than the other, okay?
We can see that quite a bit, actually.
All right, so let's go into correction mode. So we take that right hip and we put the foot flat on the table, get into hip flexion, knee flexion, okay? Yep, right like that. And so Darren, you're gonna be on the side of her, that same side, okay? And so you're gonna reach across to her opposite ASIS with that left hand of yours. Go, yep, there you go. And so open up her hip. So that same side hip, open it towards you. Let her just kind of come and open that up. Like, can she lay that out? Like her actual hip out? There you go. And so what you're going to do is you're going to instruct your client, this is the muscle energy way, you're going to have her contract against your resistance. And what you're trying to tell her is you're drawing a mechanical line from knee joint up and across to the opposite ASIS. So her job is to pull against your resistance up and across towards you, or towards the opposite ASIS. And you're just resisting that moderately as she brings that up. So go ahead and you should do it about over a 6-second count, 3 sets of 6 seconds. So let her bring that all the way up through the range of motion. Let her bring it all the way up. If that foot comes off the floor, that's okay. Yep, that's exactly right. Yep. You do that about 3 times. So as you guys are watching, we know she's got an outflare. We're firing the adductors. If she has an inflare, what do you think we should do?
Did he hear us?
Yep, so you should go into abduction is what these guys are saying.
Yeah, exactly. In that same position, you just have her abduct, okay? And so it'll kind of look like a frog leg, you know, they're kind of coming up and out and away, okay? And so we could recheck that. Typically, I don't have a lot of success with this. Doesn't mean that it doesn't work for her, but what I go to now is the Mulligan, and I'll show you that after Dr. Smith goes through here. We're trying to look and see if we have that inflare, and she's still kind of out on there. Like I said, I don't have a whole lot of success using that. So now we get our Mulligan belt.
Got it?
Okay, so we're gonna have her come slide off on the table, stand up on the floor for us. Okay. And so Darren's going to be on that right side hip, all right? And so with an Outflare, he's going to loop that around her right thigh, high into the groin. It's got to be high into the groin, okay? She can kind of take that belt and make sure it's good and high and tight, okay? Yep, you can use a towel if you want to. I typically don't, but yeah, that's awful kind of you. You guys are nice to each other. Okay. So now you strap that belt around the clinician's waist. We want that right about buttock level on the clinician. Don't put it on the low back, actually on, yep, the back hip pocket. Now, the thing with that is you may need to loosen up that belt because you want to be about arm's length here away from your client, okay? And so what you're going to do is you're going to place your hands on that ilium, that top ilium along the iliac crest. We should be kind of covering the ASIS and also the PSIS, okay?
That could be like this.
With our hands. So we're cupping like this along the lateral aspect of the ilium. Darren, is he in good position?
He's in good position. Got it.
Yeah, he may want to get a little bit more elbow extension. That belt looks a little bit low. I don't want to slip off, okay? Looks on him, yeah. Because what he's going to do is he's going to push back with his hips. So if he's got that belt around, he's like in this position, he's going to push back with his hips while he pushes in on the ilium. So it kind of looks like that.
Yep. He's we're ready to go here. Looks good.
All right, so make sure her toes are straight. She's not flaring out that foot. Yep, and then what you're gonna do is you're gonna have her single leg stand on that side, and she's gonna rotate her trunk, neck, eyes over her right shoulder. So she's gonna be turning towards you. Yep, just like that. 10 reps, okay? So single leg stand whenever you're ready and rotate around. Yep. Now what we can do while she's doing this, oh, hey, don't lose your balance. Just hold that leg up. Single leg stand for me if you can. There you go.
Okay.
And all the while the clinician is providing that lateral traction and then compressing that top ilium, okay? Now, what Darren could do too is he could provide a little bit of overpressure with the rotation. It's really important that you get some assistance if you need it, if they don't have a whole lot of motion. But also even secondarily important is that cervical spine needs to be rotating. If they're not looking over that shoulder, if the eyes don't lead the movement, we got some problems here. It's not going to be as beneficial. After about 10 reps, we rest. They're usually pretty glad to rest for a second. And then we can do another set, up to 3 sets. So this is a Mulligan maneuver. This is, I tell you what, 9 times out of 10, if I have a flare, whether it's Inflare or Outflare, this corrects it. I mean, it's gold. Now, question for the students there. Whoa, you all right? If she has an Inflare, we are going to go in what direction with her rotation?
External.
Yeah, we're going to go in the opposite direction. So we're going to go in the opposite direction. She's going to look over her left shoulder. We're still going to be in that same position if it's her right leg that has the Inflare. We're doing the same correction, but the rotation is going to be different for her. All right, so let's take the belt off. Let's see if we did any damage. I mean, help, okay?
All the way around. Your knees.
Bridge up, extend out. Don't make me a liar, Miranda. Now go in though, Darren, because that's going to really give you an assessment because that's what our objective was. Did we bring it in anymore
Ooh.
Yeah.
compared to what we first observed?
What do you feel? Feels better.
It's actually easier to now.
Yeah, you'll it's almost like a bony block sometimes. It's like, I can't even move this. And then once we free it up with that mulligan, it's like, oh my gosh, it's like butter. It actually moves now.
It was really that was difficult. It's difficult for us.
Now, chances are she probably needs to work some motor control on the other side as well with that, because you can see that she kind of wants to flop out as well in that left leg, but that's for another day. You can do that as well. It's not entirely out of the realm to see kind of a double outflare at times. Okay. So take a couple moments, practice your upslip correction either way, and then also use the flare correction either way. All right. Try that at your table with a friend for about 40 seconds.
All right, you want to
Gonna move.
There you go. That's good. That's good pop right there.
check her. And I think I'm actually going to have you scoot her back on the table to see how her knee is. Go ahead and have her do the hip bridge again.
Oh,
Yep, there you go. There you go. Now there.
the one at the end.
Don't move it.
I don't move then. I don't have any internal rotation.
Go ahead, try it. Getting the timing down can be a little tricky.
Yep, it's all about timing with that cough and also with the active leg extension, active leg kick. And so if you haven't already, try that flare technique with the Mulligan belt, as well as the muscle energy technique if you have time. About 15 more seconds here.
Dr. Doyle, can we get about another 1 or 2 minutes perhaps on this?
Yeah, for them to practice?
Yeah.
Yeah, that's fine.
Miranda, when you do that one, he got his foot. Come down here. Yep, so you're going to come around the actual ankle itself. Both hands.
Again, if you need to move me around the class and I can help assist with the best I can visually here.
Yes.
Correct, but you're going to want both hands around that ankle because you're going to pull them back into traction. Yep. Go ahead and do that a few times.
And as that leg hits the table, that's when you are pulling that traction swiftly, and they should be kicking straight out at you.
Let's try it again because your timing was off a little bit. 1, 3, Zach. 1, 2. Good.
Remember that on 3, you need help by your client. They need to shove that heel out.
Get him all the way on the table because when he's standing off, his knees are going to bend. Hands. Did you hear that, Dr. Doyle? Hands. Got to scoot back with the hands.
What?
Did you hear that? Got to scoot back with the hands, they're saying. How do we do? Okay. There you go.
Over here, we got some outflare correction going on.
Let's see some Mulligan, Outflare, Inflare correction. There we go.
Okay, so we got an Inflare on this side, Dr. Doyle.
Inflare?
Yep.
Sure.
Okay.
Yeah, I'm not doing this on Saturday.
Miranda, you could do the.
Okay, so she would probably need someone to help her because she's really struggling kind of balancing. And see how she's kicking out that hip? She's almost got like a little mini Trungellenberg. So like I would have someone stand behind her and help stabilize, or have someone stand in front of her and she can hold onto their forearms as they twist. Okay, almost like you're dancing with them.
All the way through the motion. You're gonna bring it all the way in. Up, 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 up. Keep going. Bring the
Make sure you have a firm traction with your belt going laterally and a firm blocking with your hand. So if you need to loosen the belt a little bit so you can really get into more elbow extension to really lock that out, do so. Okay. Yep. That's good. Yeah, you can use a little bit of help. Cervical spine needs to move more. You need to look over your shoulder. There you go. Look behind you. Someone's sneaking up on you. Make your eyes do the work. Your eyes need to lead it.
That hurt?
Kind of.
Why?
Oh, my hip.
So yeah, this is a great example for an inflare on that same side.
Go ahead and reach up.
You're uncomfortable?
No, it was the actual leg.
Okay. Make sure
Thin
we're all
leg.
the way on the table.
See, like this side doesn't hurt. It's the other side.
So really pay attention how it feels as you move it into external rotation and see if it's easier to do so. Yep, check your hip alignment there at ASIS, hooking that's perfect. Comparing to midline, all right. So depending on what you find, you may need to do it several times. It may be like a 3-rep type deal, okay? It just depends.
Yeah. Jeez.
Remember when you're using mulligans, it should be pain-free, okay? So make sure that is the case while you're doing anything.
Dr. Doyle, we are out of time here. I know we've gone over a little bit.
Yep.
Can you just kind of conclude things for us here, and we'll wrap it up?
Yeah, absolutely. So rotations, you probably already have an idea here to do these anyways with some of your hamstring activation. If it's an anterior rotation, we're activating the hamstrings to bring that up, okay, to bring that back. If it's a posterior rotation, then we're activating the quads to bring that, okay. Again, as I said, the sacrum, do the lumbar first. With that, you can utilize a MWM snag technique to do that first before you address the sacrum. So regardless of how you correct it, always try to address the lumbar and then the sacrum to follow. All right, so rounding it up, regional interdependence is the concept that patient's primary musculoskeletal symptoms may be directly or indirectly related to, influenced by impairments from various body regions and systems, regardless of proximity to the primary symptoms, meaning that something else could be driving the issue. So we need to investigate that. And so I have just some cases here. All of these cases are athletes that are female, and they complain of any kind of lower extremity issue. And they were about a 7 to 10 of pain. When I did a puffer's hip alignment and correction, they improved their pain immediately, dropped it from a 7 to a 2 in that actual regional site that they're having pain, even though the hip wasn't really involved. And some common areas that I found was they had an upslip on the chief complaint side, and they had an outflare on the chief complaint side. And then after about 7 days, they had zero pain as reported. So we had an MCID in these cases of pain reduction within 24 hours. So this could be something that unlocks the rest of the lower kinetic chain if we treat accordingly. So, hey, remember, it's all in the hips, as Happy Gilmore would say, okay? Just a shout out to my employers, IU South Bend, RMU, and Beacon Health Systems. Thanks, y'all. I got my references on the slides to follow if you want them.
Thank you, Dr. Doyle. We appreciate your time here today. And I understand you have a survey regarding the online experience that these guys have got. It's about 12 questions. So if you guys could please make sure you get that filled out to give him a little bit of feedback, and that'll guide us in doing some stuff in the future. So Dr. Doyle, thank you so much. We appreciate your time and your insights here.
Hey, thanks for having me. Talk to you later.
All right.
Bye.
Here at the channel, we're dedicated to establish and foster a positive interprofessional environment in which learning can occur regardless of your profession and/or previous training. Please help us spread the word to your healthcare movement colleagues looking to incorporate more evidence-based research application into their own practice. As always, if you liked what you see, please subscribe and join our YouTube channel community, where the #1 goal is improving the lives of those we serve. A big thanks for hanging out with us over this extended time today. We'll see you in the next video.